Good afternoon or good evening. As we discussed last week, most of the information that we will be sharing will be based on what is on the GOLD guideline, the standard treatment guideline from South Africa, and data from up to date. And let's brave that smoke and fire of COPD by reminding one another the most important thing is that, yes, it is a disease. Some of the people did smoke, but not all of them would have smoked for us to just feel defeated. This is a condition that is not only preventable, but also treatable. And the second part of the discussion today or the presentation will try to cover how do we manage those patients. So we all know how it presents, and from last week we learned that it does matter that we know which type of patient with COPD are we dealing with. And the type of patient that we deal with is all based on what are the same symptoms, what is the severity of symptoms that our patients are displaying, and what are the risks based on exacerbation history. Putting everything together, we will know which type of patient are we dealing with. That's why we call it you box your patient. It is not only about shortness of breath, because COPD is more than shortness of breath. That's why there is also a room for us to use the CAT beyond the MRC that deal only with shortness of breath. As we can compare there on the left side, you see, we can all see and appreciate that the MRC, the modified MRC, focus mainly on dyspnea or solely on dyspnea, while the CAT have more than the dyspnea, because as we all know, COPD is dyspnea, cough, and sputum production. And talking about risk, it means that whenever we see our patient, we need not only to restrict ourselves in putting an assessment of COPD, but get to educate our patient and remind ourselves that it is critical that we know of the history of exacerbation, particularly moderate to severe exacerbation. And talking about exacerbation, we know that it is every time dyspnea, cough, or sputum production have increased in severity, or when it comes to sputum, it is volume and change in character. So, and we did remind one another, because exacerbation that matters a lot when we need to box our patient is about moderate to severe. We need to be able, whenever we take that history, to know which type of exacerbation did happen, so that we can decide that the treatment that we give to our patient is appropriate or not. So as we say, it is mostly moderate to severe exacerbation that matters the most when you have to box your patient. And therapy-based severity metric will mean that every single patient with exacerbation that would have been treated with more than SABA will qualify or should be flagged as significant whenever we take the history of exacerbation. We spoke also about symptoms-based metric. It's not only which treatment was used, but how many of the cardinal symptoms were involved in the definition of that particular episode of exacerbation that will matter. So every patient that comes with at least two of the three, meaning cough, shortness of breath, and sputum production, will be considered to be significant. Being admitted at the hospital is per se significant when it comes to exacerbation. So those things, we spoke about them last time. So when we box our patient, there will be either A, B, C, and D. It doesn't matter, because at the end of the day, this will allow us to get the treatment that is most precise for our patient. And currently, if we go by gold standard, a patient with COPD-A will get chronic stable COPD patient will get SABA only. They can be offered the SAMA, but SAMA are not first line therapy for rapid reliever, as a rapid reliever. And A will be offered SABA, B will be offered LABA or LAMA, while C are expected to be absolutely on LAMA. And whenever the patient is a D, that patient can be on LAMA or a combination of SABA and LAMA, or a combination of ICS and LABA. So, but when you are in South Africa working in public sector, the treatment that your patient is expected to be on is, if they are A, meaning they have a MRC that is 0 or 1, and have had during the past year only one exacerbation at max that didn't lead them to hospital admission, that patient or those patients should be on SABA. But once they have symptoms that will be graded 2 or greater on MRC, or 10 or greater on CAT, those patients should be on LABA. And patient being it C or D, when you are in public sector, you are restricted. The only best treatment that you can offer to them, and that is recommended and available by standard treatment guideline, will be a combination of ICS LABA. So contrary to gold that differentiates C from D when it comes to treatment, in public sector, both C and D are offered the same treatment, which is a combination of ICS LABA. And so the take-home message here will be, wherever we are, no patient should be on salbutamol alone if the symptoms by MRC will be graded 2 or greater, and no patient that has been experiencing more than 2 or more exacerbation, even that didn't lead to hospitalization, or 1 or more hospitalization that that was indicated because, or that was prompted by exacerbation, those patients should not be on SABA alone, or be on SABA and ICS alone. Those patients should absolutely be on LABA. So when we say treatable condition, it should be treatable condition with the best therapeutic modalities that are out there. We need to remind one another. So whenever you decide to put on somebody's prescription SABA and beclomethasone for COPD, please step back and remember if there is not something better that you should be considering for that patient, because once you consider ICS, it means that patient should be having LABA, not SABA alone. Yes, for rapid relief, any patient, being it A, B, C, or D, will need a SABA, but SABA will never be a treatment that will be combined or prescribed with ICS in the absence of a long-acting broncho beta agonist or a long-acting muscarinic. So please let us remind ourselves about those facts. And how many times did we prescribe ICS? How many times did we prescribe beclomethasone to our patient? Many times. But whenever you want to initiate ICS in your patient, now that we know that whenever you think of ICS for COPD, you should be thinking of long-acting bronchodilator. But even when we did prescribe ICS without that in mind, did we care about, was it really indicated with offering the maximum benefit to our patient? Was it marginally indicated, or was it even supposed not to be offered to our patient? Because how many patients with COPD are out there being prescribed beclomethasone and salbutamol without us referring to the fact that ICS, there might be clinical situation that will not be warranting ICS to be prescribed. So going forward, we need to know that what will help us decide that the prescription that we made of ICS for our patient is supported with strong evidence and is highly recommended. It will be the patient blood eosinophil count. So going forward, because it is a treatable condition, because some of the tools that we need to offer to our patient therapeutically, this tool or that tool will be ICS, we need to remember that prescribing ICS is based on the patient blood eosinophil count. So every single patient that we see and treat for COPD going forward should have eosinophil count documented in the folder, particularly if we decide to put the patient on ICS. So strong support for ICS in our patient that are suffering from COPD will be patient that is providing to you the history of hospitalization for exacerbation. That is why it is critical to educate our patients about reporting to us that they've been admitted or they were admitted for a COPD exacerbation. That is why it is critical for us to keep count of exacerbation, as we reminded one another at the beginning. Moderate exacerbation are those exacerbations that matters the most when it comes to ICS. So when they got 2 or more moderate exacerbation in the past year, those patients are strongly candidate for ICS. And whenever you pull blood and the blood eosinophil count is 300 or greater, those patients should ideally be offered ICS, or if you happen to offer them ICS, you know that you've offered them a therapeutic modality that will be the most beneficial, or that will be mostly beneficial to them. Also, because asthma and COPD can overlap or be concomitant, when you have a patient that have both asthma and COPD, ICS comes in handy. In the middle ground, when it comes to ICS and COPD, will be patients that only have 1 moderate exacerbation per year, or patients that have blood eosinophil count that is between 100 and 300, less than 300. So equal or greater than 100, but lesser than 300. And it is not recommended, and the ICS should be avoided in patients that have repeated pneumonia, or patients that have blood eosinophil that is less than 100, or patients that have history of mycobacterial infection. So ideally in South Africa, every single patient that seek care should be screened for TB, and if a patient has TB, we should avoid prescribing ICS for COPD until TB is ruled out, or until TB treatment has been started or has been completed. And those are some of the side effects that we need to remember. There are a lot of patients that are on ICS that come to us with, we usually recognize oral candida, but we forget that hoarseness of voice or irritation of the throat can be linked to ICS, and this patient will be coming to us and we don't know the reason why, or we cannot explain to them the reason why the voice have changed. Same apply whenever somebody is offered ICS and they come with lower respiratory infection. It might be just being easy for the patient to get that pneumonia because they were on ICS. Talking about ICS, we need to bring up the issue that there is almost no room for oral glucocorticoids. So no patient should be on chronic prednisone because of COPD. We can use them in exacerbation, but they should never be part of long-term therapy when it comes to COPD. And again, while we are there, because we say we are boxing our patient to get the best treatment out of that box, when it comes to theophylline, again, just to remind one another, no patient should be kept on theophylline if 12 months later, if there is no benefit. So it means a patient that remains symptomatic on theophylline should no longer be offered theophylline if they've been on it for 1 year or more, or for at least 1 year, you need to stop it. Another critical thing is that it's not only that we give them the correct treatment, but are they using it the proper way? And it does matter that at every single visit, not only we take care of grading the severity of the disease / symptom, using the CAT, focusing only on dyspnea, or expanding the assessment using the CAT that have more than dyspnea, and taking the history of exacerbation, particularly the moderate one, and the one that are severe that led the patient to hospitalization. It is critical that we assess the patient inhaler technique, because this is or could be one of the reasons why the patient or the goal of therapy are not been have not been achieved. And this wanted to cover this based on one of the questions that was some of the question or inquiries from the last talk. Treating COPD is not only about treatment or about therapy, it is also about non-pharmacological therapy. And one of the things that is critical is to get the patient to stop smoking. Unfortunately, up to 40% of patients that are diagnosed with COPD are still smoking. And when they smoke, that behavior will negatively impact on the prognosis and the progression of the disease. So we need to be mindful of that fact, and treating COPD doesn't mean overlooking the fact that these patients should be motivated and assisted to stop or to stop smoking. And this can be achieved, but it requires effective resources, and it does also require time for us to get our patient to successfully quit smoking. As you can see, where we have resources, when resources are put into play, and when time is devoted to deal with the 5A and the 5R of smoking, you can get patient up to 25% quitting smoking. So you need the resources and you need time for that. Why does it matter? It does matter to stop or quit smoking, because the natural history of COPD can be impacted even in those that had COPD when they already have COPD. So the sooner they stop, the better for them, and it will be easier for them to avoid disability or death that is caused by smoking through COPD. As we say again, we need to get acquainted and remind ourselves about the 5A. Every time that you see a patient with COPD, you need to ask, advise, assess, assist, and arrange for those that are willing and ready to quit smoking. And talking about arranging and assisting those patients, one of the things is nicotine replacement therapy, because it has been shown to reliably increase the long-term smoking abstinence rate in patients that have COPD because of smoking. So we need to learn what are the formulations that are available out there, and not all of them need prescription when it comes to nicotine. People must know that nicotine replacement therapies can be accessed even over the counter, and it does help a lot. And we need also to remember, whenever we think of nicotine, there are instances where it might be contraindicated for a short term. It is when patients have had what they say a recent myocardial infarction. It means under 2 weeks, even if the patient wants to quit smoking or want to quit smoking, you cannot prescribe nicotine therapy until it is beyond 2 weeks post MI. And they also talk about the recent stroke, not stop. The nicotine replacement therapy should be withheld for recent stroke. But what about patients that are not ready to quit yet? We need to remember the 5R, because we've been used to talk about 5A. We can all recite the 5 A's, the ask, advise, assess, assist, and arrange. But that applies only to patients that are willing to quit smoking, that are ready to start that process of quitting. What about patients that are not ready? We need to remember the 5 R's. It's just things that you need to get out of your patient, not out of you as a clinician, about the relevance of quitting smoking, the risk of continuing smoking, the rewards that they get from stopping smoking. What are the roadblocks that are they making it difficult for them to quit smoking? And you need to remember that that motivational process should be repeated every time that you see your patient. So taking home message, 5A, yes, but that is applicable only for patients that are ready to quit. Those that are not yet ready to quit should be going through the 5 R's. Additional to smoking cessation should be all the immunizations that are critical, being it influenza, being it SARS-CoV-2, being it pneumococcal or pertussis for those that were not vaccinated when they were adolescent. Additionally, also to therapy should be pulmonary rehabilitation with exercise training that are specific to COPD, because they do. Pulmonary rehabilitation does improve exercise capacity, does improve symptoms and quality of life across all grades of COPD severity. Pulmonary rehabilitation reduces hospitalization, it reduces anxiety, it reduces depression. So we treat, it is a treatable condition, but the treatment of COPD is not solely based on pharmacological modalities. They are non-pharmacological modalities that are there that should be offered to our patient. Same apply, and our patients should be educated that there will be time, or some of the patients who might require long-term oxygen, particularly when they have severe chronic resting hypoxemia, because it has been shown that it does improve survival. And we need also to be mindful of the fact that we might do everything, and but still not stop the progress of the disease. And some of our patients should be prepared and the discussion about palliation should be part of the management of COPD. So that was COPD chronic stable. We'll just try to go quickly through COPD exacerbation, because that is one of the way that COPD can present. And whenever we think of exacerbation, we know the definition by now. We know how to grade the exacerbation by now, but we need also to remember what might be the differential. Those differential are heart failure, cardiac arrhythmia, pneumonia, PE, pulmonary embolism, pneumothorax, and today we should also add COPD. So somebody can come there with symptoms and sign of COPD that have increased and that have led to a change in the therapy beyond the day-to-day variation just because they got COVID. So we need to keep that in mind. So what are the objective tests that we do in COPD? So when you have a patient that comes to you and you make an assessment that they are going through exacerbation, those are the tests that we need to consider. Saturation should be measured. There will be a need for the patient to get a chest X-ray, and there will be also a need for the patient to get blood drawn. So why do you need and when and how do you need oxygenation to be measured, or the pulse oximetry? Ideally, the patient should get continuous assessment of oxygen saturation whenever they are going through exacerbation. I don't remember, we only have 1 or 2 pulse oximeters that are going around in casualty, for example, in our setting. So the recommendation is that whenever you assess, the patient should keep the probe on the finger until exacerbation is over, which is not the case currently. And when COVID came, even ourselves privately, we went and procured our own small pulse oximeters for the patient for assessment. And that excitement when it comes to monitoring saturation almost never exists when we deal with COPD patient. We need to remember that that is one recommendation. Your patient, you make an assessment of COPD exacerbation, ideally make sure that they keep the probe on the finger. And the other thing that we need to get from a patient that has exacerbation is a chest X-ray. It is important because it does help us to differentiate possible alternative diagnosis that might be heart failure or pneumonia or COVID or pneumothorax. So that's so not only we measure the saturation and we do it continuously, but as soon as possible, we make sure that we don't miss any alternative diagnosis. Blood-wise, do we need CRP all the time? We need to remember that the indication, if CRP will only be used for us to decide to put our patient on antibiotic or not, it doesn't show to add value, because the criteria for the patient to be offered antibiotic in exacerbation those criteria are not based on CRP. So this is something that we need to remember. You will pull that CRP, but you should not delay initiation of antibiotic when the clinical indications are made, just because you wanna get a proof that CRP was elevated or not. And is it always necessary to do a peak flow meter or to do spirometry in a patient that have exacerbation? As you can see there is a recommendation against assessing or using a peak flow in a patient, or offering a peak flow, or thinking of using a peak flow meter or spirometry in patient with acute severe exacerbation. So what are the main therapy? Being it asthma or COPD, the main therapies are short-acting bronchodilator for COPD, contrary to asthma, although you will see that there is always asthma popping. Asthma is popping because when you go through the standard treatment guideline in South Africa, the management of exacerbation for asthma is copycat the management of COPD, or the other way around. So you treat COPD exacerbation the same way that you treat asthma exacerbation. But this talk is also to remind us that there are things, if you want to treat properly, the standard of care when it comes to COPD exacerbation is different from the standard of care when it comes to asthma. And one of the critical things that we need to remember, antimicrobial are only part of the management of exacerbation in COPD, but not in asthma. In asthma, you need to prove that there is infection, while in COPD, there are set criteria, clinical criteria for you to consider, and you should consider offering antimicrobial therapy to the patient. So the main therapy again are SABA, that would be repeated. It is a repetitive administration, and that repetition is also different when you compare the standard international recommendation, when you compare them with the South African treatment guideline. It's just for you to be mindful. If you see a colleague that take longer to repeat nebulization on a COPD patient, don't kill that patient, that colleague, because that colleague is only applying the most current and evidence-based recommendation, because you should not be nebulizing COPD patient every 20 minutes the same way that we nebulize asthma patient. So beside the SABA, beside the antibiotic, patient will also be having control a flow of oxygen supplementation. So as we see there, if we reverse airflow limitation, if we treat infection, if we ensure appropriate oxygenation, we would be able to avert intubation and medical ventilation in our patient. That is why it is critical that we know of all those principles and we adhere to them. So as this is just a reminder, and COPD. In COPD, antibiotics are recommended by most clinical guidelines for patients that have moderate to severe exacerbation requiring hospitalization. So it is again the grading of exacerbation is again reminded to us. This is not only to say the patient had an exacerbation of COPD, but which type of which grade of exacerbation, because not only it tells us, it will later on tell us where the patient will be boxed, but it does also tell us in the instance where the patient is going through exacerbation that there is an indication or not for antibiotic. So when it comes to oxygen, just to remind all of us, been comparing asthma and COPD, we need to remember that oxygen is a critical component of management of exacerbation. But again, the target, we need to remember the target of saturation is that we give oxygen to our patient if we have access to a blood gas to get partial arterial pressure of oxygen between 60 to 70. But if you only have access to a pulse oximeter, you should not push your patient saturation above 92. So everything between 99 and 92 is enough. So we don't blow that oxygen to go beyond the 92 or trying to get to normal saturation. Because again, when you titrate to less than 92, between 88 to 92, as you can see, you minimize the risk of worsening of hypercapnia, and it does reduce the risk of your patient to die, because whenever you give excessive oxygen, you increase mortality in your patient with COPD. So don't just crank that oxygen up to the maximum. Don't go for 60%, don't go for 90%, or whenever you give oxygen, remember that is one of the reasons why continuous pulse oximetry is critical, because it will assist you and your patient to titrate oxygen to keep saturation between 88 and 92. So those recommendations, those numbers are not just falling from the sky. Those numbers are there to avoid or reduce mortality. This is, again, just papers that have shown what you should be doing. But if you give more than it is required, you know that you will the oxygen will lead to acute hypercapnia, and your patient might your patient outcome might be compromised. The other thing that we need to remember is that whenever you use you want to deliver oxygen to your patient, the devices that are recommended in COPD are either the nasal cannula or a face mask. Ultimately, as you can see, all that you need is to be able to deliver approximately 40% of FiO2 to your patient. And when you use a simple face mask, as you can see again, by opening 6 to 10 liters per minute, it will be up to 55% of FiO2 that you give to your patient. And again, whenever we pull up a venturi mask and wanna deliver oxygen to our patient, we should remember that not all venturi masks are the same. It is all based on the color, and if you cannot remember the color, what you need is to go read, because not all venturi masks deliver the same FiO2. So if you only if you use the green one, for example, you know that by blowing oxygen through that mask, you might be delivering more than it might be required, or you should be able to titrate down the oxygen for you not to give excess oxygen to your patient. So to finish up with the short acting bronchodilator in COPD, all that we need to remember, again, it can be used as, you can use them through nebulizer, or you can use them through MDI, as long as the patient can correctly synchronize. But again, in the COVID, it's only recently that we are becoming more and more relaxed. There was a time where we couldn't even nebulize our patient, and if the person can synchronize, and if the patient can, if we can have access to spaces, even MDI can still be used and help our patient to get the effectively assist our patient. So I will just finish the talk with the dose. As you can see, for asthma, it is 5 milligrams of salbutamol whenever we use the nebulizer, while ideally in COPD, it should be half of that. It should be 2.5 milligrams of salbutamol. You still use the same amount of oxygen liter per minute to get it delivered, so that it is completed within 10 to 20 minutes. And we discussed already that we can use the nebulizer, or we can use the MDI. This is just to remind us, in summary, when you treat asthma, it is 5 milligrams of salbutamol every 20 minutes, 3 doses within 1 hour. Then after, when the patient has responded, you can now start every 1 to 4 hours. There are people that also recommend that you start now giving that 5 milligrams every 2 to 4 hours. It can be coupled with ipratropium bromide. This is for asthma. But if you were treating your COPD exacerbation by standard treatment guideline, this protocol will apply. While in fact, when you are treating COPD exacerbation by standard, by international standard, it is 2.5, meaning half of the dose that is given every 1 to 2 hours, not every 20 minutes, for 2 to 3 doses. So 3 doses in asthma will be completed in 1 hour, while 3 doses here for COPD will be completed basically in 3 to 6 hours. So you give a little amount of salbutamol in COPD exacerbation for a longer period, and only later on, then you will be giving that 2.5 milligram of salbutamol every 2 to 4 hours. So I brought up this issue so that we are mindful and we know, and people that will treat the patient based on international standard will be offering the best treatment, because the 5 milligram of salbutamol has not been shown to be more effective for your patient with COPD, and it might even lead to complication. So that was our talk for today. I hope that we will remember that we are dealing with a treatable condition. We need to remember to not only categorize our patient with COPD, but whenever we categorize them, what do we use? And later on, when we treat them, there will be specific ways that can be different from the way that we treat asthma. Thank you very much.
Thank you very much, Dr. Kayembe. Excellent. I've always wanted to get to this level of detail with COPD, so that was very satisfying. Thank you very much. I'd like to check if there's any questions. People can either put things on the chat, or you're also happy to just unmute and speak, or to put a hand up, whatever is easiest. There's a hand up. Yes, Dr. Mpinda, do you want to just unmute?
Yes. Thank you very much. Thank you, Dr. K. It was excellent. My first question, with regard to the low saturation target, you say around 88 to 92. I thought that it was that evidence are not available. So it's like it's not something to go after, but I got the impression that you were saying that we should stick at that value. I'm not sure if I heard you correctly. That's the first question. The second one, it's I see COPD patient going around with mucolytic. I'm not sure what do you say? Do we give them mucolytic? Because remember, one of the symptoms that they produce sputum. They do cough with or without sputum, but when there is sputum coming, they have a tendency to fix it. So some of our colleagues do give mucolytic. I want to see what are you saying. That's the second. And now I'm in primary healthcare, I'm in the clinics, but you are in a hospital setting. I want to know, when a patient is admitted with exacerbation, do you bring on board the physiotherapist? Do you also bring on board the psychologist? As you say that motivational interviewing, aiming at quitting smoking is very important when you're referring to the 5 A's and the R's. So what is the practice in your setting? Thank you.
So let's start with the slide is there and the references are there. So there are evidence that the more oxygen you give to your patient, the higher the mortality in COPD. So evidences are there is not a recommendation without that is not backed. So that's why we should stick to 88 to 92 whenever that's why not only you need a pulse oximeter on your patient, but whatever you started with, you need to be able to go there, dial down, dial up, and make sure that you don't go beyond the 92, because when you go beyond the 92 in COPD, you increase mortality. So what would have killed that patient of yours is not tobacco, but you and your oxygen. So mucolytic, it is among the therapies that are not really recommended currently by GOLD. There are a lot of therapies that are there that people are throwing out there to patients, but it is not really first line therapy for your patient. Give your patient LABA, give your patient ICS when it is indicated, get your patient to quit smoking, treat infection exacerbation with antibiotic when it is moderate or severe, and your patient will not need mucolytic therapy. And the physio, I don't know what is happening in the ward. I'm at the hospital, but I also work in OPD, but quitting might be not addressed while the patient is in the hospital, but follow up post discharge should, that's where I think the psychotherapy might be started, or motivational counseling will be initiated. What else did you ask about? Was about the physio in the ward. I don't know if they call them, but most probably they should be parts if multidisciplinary way of dealing with disease is the modality that is adopted in the ward. Maybe some of the people that work in internal medicine would tell us something. So, but the 92, there are data out there. We should not be giving more than that.
Thank you very much. That's very helpful. It's always great to have specific targets and numbers that we can work towards rather than just randomly prescribing treatment. Is there any last questions before we close off? We've just done an hour exactly. Excellent. Oh, there's I'm just noticing there's a question in the chat about leukotriene receptor antagonists in COPD as opposed to asthma. Dr. K, do you want to make a quick comment on that?
I didn't read about it, but I don't think that they were, the PDE5 inhibitors were part of the discussion. I cannot pronounce myself on that.
Thank you very much. I'm going to close this meeting now, and we will make the recording available as usual. I'm actually on leave next week, so there won't be a session next week. And then Dr. Kayembe, are we picking up again from July?
Yes, no problem.
And are we moving on to asthma, or what is your next?
We'll go to we'll see also with the other people that are coming.
Yes, that's true. We'll have a new interns coming.
Then we'll decide on which topic we'll start with.
Thank you very much. Thank you very much for making the time and the effort available. And everybody have a lovely evening.
Bye-bye.
Bye-bye.